Okay, we are live now.
Thank you.
Thank you.
Good morning, everybody. Welcome to our September Commonwealth Health Insurance Connector Authority meeting. I'm Kate Walsh, I'm the chair, and I'm glad to see you all here today. I guess I need to start the meeting by opening the meeting. Can I have a motion to do that, please?
So moved. Motion.
Seconded.
And Kathy, do I need to have you do the roll call now? Or is it after I approve the minutes?
No, we do the roll call to open the meeting.
That's right. Okay, thank you.
Okay, good morning, everyone. Rebecca.
Present.
Michael.
Present.
Eric.
Present.
Martha.
Present.
Dimitri. Okay, I'll come back to that one. Secretary Walsh.
Present.
Matt.
Present.
Rena.
Hi, Kathy. I'm here.
Good morning. Nancy.
Morning, Kathy. I'm here.
Good morning. Pauline.
I'm here. Thank you.
And once more, Dimitri. Okay, thank you, everyone.
Okay, well, we're all in unmuted and in present mode. I'd also like to ask for a motion, a second, and a vote to accept the minutes of our August meeting.
So moved. Second.
Okay, we ready?
Yes, thank you.
Hey, Rebecca.
Yes.
Michael.
Yes.
Eric.
Yes.
Martha.
Yes.
Secretary Walsh.
Yes,
Matt.
Yes.
Rena.
Yes.
Nancy.
Yes.
Elaine.
Yes.
And I'll see if Dimitri has joined us. Okay, thank you, everyone.
thank you, Kathy. It's always great to get those two things out of the way early, and often we have a packed agenda today. So I look forward to a robust discussion. And to start that off, I'd like to ask our Executive Director, Audrey, to open the meeting.
Great. Thank you so much, Secretary. Good morning to all of our board members and welcome to today's meeting. It is great to see you all as we dig in and provide updates on two of the larger initiatives the organization has taken on in years: MassHealth Redeterminations and Enrollments, and enhancements to our Connector Care program. And both of these on top of our annual preparation for the upcoming open enrollment period. These items have been driving our work on a daily basis and will be part of all of our conversations today. Throughout today's meeting, improvements to and expansion of Connector Care will take center stage. I want to take a moment to pause on Connector Care and acknowledge that as we walk towards 2024 open enrollment, we are walking into a Connector Care plan year that is unprecedented. It's unprecedented because in the 17-year history of the Health Connector, there has never been a Connector Care program that will be as strong, as stable, and as member protective as it will be this coming year. This is for a few reasons that I'd like to briefly highlight, just so we don't risk losing the forest for the trees here. First, thanks to the state's FY24 budget and the actions of this board last month, this open enrollment Connector Care will be expanded to people with household incomes up to 500% of the federal poverty level for the first time, offering new financial support to moderate income residents and families in the individual market. This will mean lower premiums for tens of thousands of people. It will also mean dramatically lower cost sharing, lower by thousands of dollars a year, removing barriers to care, financial strain, and reducing the risk of medical debt. Second, we are doubling down on the health equity focused benefits that Connector Care members receive, like $0 prescriptions and services for managing chronic illnesses like diabetes, asthma, and hypertension. We are finding new ways to publicize and highlight these benefits in communities all across the state in an effort to reduce health inequities. Third, new for this open enrollment is the inclusion of all marketplace carriers in the Connector Care program, which means 3 new statewide carriers become participants in Connector Care. This is a significant step forward for 2 reasons. One is simply a matter of fairness and parity, and to finally move past operating 2 side-by-side marketplaces with different options, one for low-income people and one for everyone else, and to come into alignment with the vision of the ACA, which is one marketplace for all with subsidies available to support those who need help paying. The other reason is to shore up coverage in areas of the state where Connector Care enrollees have sometimes had only 1 or 2 carrier options, making the program unstable and vulnerable to shifts in carrier strategies and depriving enrollees of choices, even while other carriers sold individual market coverage to higher income individuals in that very area. So this change is a significant one, and it was paired with a needed cleanup of outdated and inconsistent network and program participation rules. These changes meant new operational work to onboard into the program for the new carriers, and it also meant an altered program and market landscape for all carriers in service of these needed changes to make a fairer marketplace. So I want to acknowledge the cooperation and partnership of carriers in implementing and adapting to these changes. I also want to acknowledge the tireless work from my staff, from plan management, policy, operations, IT, finance, legal, and others. I personally believe that this was the most strenuous seal of approval process we've executed in years, and I'm grateful for how diligent, creative, and resolute they were in developing and implementing responses to programmatic problems that would have been far easier to let fester. Today's open enrollment and seal of approval discussions also include details on Division of Insurance approved rates for 2024. The high cost of healthcare is something we've discussed regularly here, as it affects the enrollees we serve and the programs we operate. Overall rate increases as we move into 2024 are at 3.2% in the merged market, and that is certainly lower than we've seen for the last several years. So that's welcome news. Underneath that market average, there are some outliers, particularly in the silver tier, among the carriers newly joining the Connector Care program. Many of these silver plans land beyond the point at which we can smooth the difference in a meaningful way for enrollees for this first year in the program. As we've been chiefly focused on the operational side of bringing these new carriers into the program, now that they are in, we expect to next pivot to work closely with these carriers in the coming year to determine how they bring their underlying premiums down to levels that will be more in reach for Connector Care members, so that we can fully realize for our enrollees the promise of having full market participation in Connector Care. These conversations will take place against the backdrop of the system-wide healthcare cost challenge at the broader state level, as highlighted in the Health Policy Commission Cost Trends report that was issued yesterday, which shows that as a state, we're moving in the wrong direction on healthcare spending and costs. The Connector welcomes the opportunity to work with other state agencies and others to develop long-term solutions to the real financial and healthcare access problem that affects everybody in Massachusetts. In the meantime, our job at the Health Connector remains focused on access and using the tools we do have as a marketplace to buffer enrollees from cost barriers where we can. The changes to Connector Care come at an important time as we continue the Medicaid redetermination process, welcoming thousands of people a month into new Connector coverage, with many people eligible to get into expanded Connector Care this fall and next year. We're now about a third of the way through the redetermination period, and our processes have gone as planned. And since April, we have seen over 31,000 people formerly on MassHealth enroll in Connector coverage. We're seeing about a quarter of Connector eligible people enroll in new marketplace plans, which is higher than many other states and significantly above the low single-digit movement from Medicaid to marketplace that we've typically seen at a national level. Through outbound calls and surveys, we're starting to get a sense of where people who don't end up enrolling with us land. Many are landing in employer-sponsored or other coverage. It may take time for us to fully understand the entire coverage picture, but the early readout bears some cautiously encouraging signs. The team will walk you through more details of how we're communicating with residents losing MassHealth and what we're doing to get them into new coverage, and how we're testing our strategies to see what works best, as well as an update on our open enrollment readiness. Redeterminations and open enrollment will remain our priority items in the short and immediate term, but we continue to plan for what's next for the Connector. We continue to work to develop a new proposed strategic plan framework for your consideration later this year, looking to where we want to take the Connector's work over the next 3 to 5 years. We've had really productive individual conversations with each of you, as well as internal staff, and are now turning shortly to solicit feedback from external stakeholders and others, gathering input on our areas of focus and our medium and long-range goals. As always, thank you so much for your thoughtfulness and enthusiasm for our work during this really unique and busy time. And I think we can move into our agenda unless there are any questions. Oh, Secretary, I think you might be muted.
I'm sorry, I'm looking for the mute button. Any questions about what she just asked for? I thought it was a great summary. We do have a lot, so maybe there'll be more questions as we get into the meat of the presentation. So I'll move us along. The next item on our agenda is a presentation on an update a more detailed update on MassHealth redetermination and enrollment transitions, which will be presented by Marissa Woltman, Nelson Teixeira, Jason Lefferts, and MassHealth's Chief Operating Officer, Elizabeth LaMontagne. And I think Marissa kicks this off.
That's right. Thank you and good morning.
Morning.
Okay, here we go. So we're returning today with the latest in the ongoing process of MassHealth redeterminations, through which over 31,000 individuals have transitioned to QHP coverage since April. We're pleased to be joined again by Elizabeth from MassHealth, and we'll share updates on enrollment, outreach, and operations. I'll hand it over to Elizabeth.
Thanks, Marissa. So we are in our 5th month here of redeterminations at MassHealth. And since April 1st, we've initiated renewals for about 440,000 members from April 1st through the end of July. Throughout this process, our focus has maintained on preserving and preventing administrative loss of coverage as much as possible, ensuring members understand and can complete key actions to maintain the best benefit they're eligible for, and ensuring we remain compliant with federal and state requirements. To give a little overview of how we've seen our caseload change since April 1st, we've seen our caseload decrease 0.61% from 2.4 million members to about 2.39 million. Prior to the COVID-19 public emergency, we saw about 52,000 members depart MassHealth coverage each month. That number is important context when we start looking at some of the monthly departures that we're seeing. For instance, in July, we saw about 61,000 members depart coverage, and we do expect this number to increase significantly into the fall as the redeterminations process continues. When we look at the reasons why these members are departing coverage, about 61% of members have departed coverage because we've been able to confirm that they are no longer eligible for MassHealth. About 35% have departed coverage due to procedural reasons, such as not responding. We do expect the number of procedural terminations and the percentage closed for procedural reasons to increase as we continue this process. This data is through the end of July, and our September dashboard, which will include data through the end of August, will be released later this month and available on our MassHealth Renew website. Throughout this process, as I mentioned, we're really laser focused on preserving coverage for individuals who are eligible. And this is really in 2 key areas. The first is doing everything we can to automatically renew or auto-renew as many members as possible. And when we are able to auto-renew someone, this means we're looking at data on file and comparing it against federal and state data sources. And if we're able to use that data comparison to confirm that someone's eligible, we can renew their coverage without requiring that member to take action or return that blue envelope that we're sending other households. We've recently sought and received federal approval to enhance our auto-renewal processes. And as a result, we've been able to achieve an auto-renewal rate of about 75% for individuals under 65 years old and who did not have their coverage protected during the public health emergency. For individuals under 65 who did have their coverage protected, that auto-renewal rate is significantly lower, below 10%, because these are individuals who have less recent information or who we already tried to auto-renew and were not able to during the public health emergency. We've also requested and hope to be able to implement an enhanced auto-renewal process for individuals over 65 or individuals with disabilities later this month or early this fall, which we hope will also increase the number of members who are auto-renewed through that process. For individuals that we're not able to auto-renew, we're really focused on making sure we're outreaching them around the time of their renewal. So in addition to the text and email and calls that we're doing to these members, we've also been coordinating closely with health plans. And health plans have made over 400,000 outreach attempts to members to make sure that they know the action that they need to take to complete their renewal and receive the best benefit they're eligible for. We're also working to execute a new federal flexibility, which would allow health plan staff to directly assist members in completing their renewals. Through our partnership with Healthcare for All, we're also really focused on the 15 communities with the most members at risk of losing coverage. Canvassers have knocked on over 350,000 doors, and community-based organizations have held over 1,000 events in these communities. And outside of this, we're also continuing our broader outreach efforts, including finding new avenues to reach our community, such as working with over 50 market baskets, 600 libraries, and 1,800 schools in the Commonwealth. As some of you may have seen, on August 30th, CMS did release new guidance around ex parte or automated renewals. We wanted to just share a little bit about what this means broadly and what this means for Massachusetts. This guidance is really focused on making sure that those automated renewals are done at the individual level, not the household level. And CMS's guidance is most focused and most concerned about states that may be disenrolling members procedurally, particularly kids. As you know, kids often have a higher income bar for eligibility for adults, which may not be appropriately considered if these automated renewals are done at the household level. A great scenario here is if you have a family of 4, and in the ex parte or auto renewal process, you can see that those 2 kids are eligible, but you need more information from the parents. In the scenario in which parents don't respond, the CMS guidance is really clear that those kids should maintain their eligibility because they were individually found eligible through that automated renewal process. States who are not compliant with this guidance can implement mitigation strategies in the short term to reinstate members or defer renewals for up to 12 months as they update their systems to come into compliance. CMS's main concern, this disenrolling of eligible children if their parents don't respond, is not an issue in Massachusetts. HICS, our shared integrated eligibility system with the connector for members under 65, processes auto renewals at the individual level. And furthermore, as of September 8th, we had the lowest percentage of disenrollments that are kids, 18%, compared to other states reporting age breakouts. And we've actually seen our total kids caseload enrollment increase since April 1st. I will flag that for MA21, our legacy system that processes eligibility for members over 65, there are a few limited populations that will require reinstatement or deferral of renewals, largely households of more than 1 person, where the individuals have different eligibility rules, such as when one spouse is receiving long-term care and the other is living in the community. I know this one's a little technical. Marissa, I'll pass it back to you, but obviously happy to answer any questions folks may have. Nancy?
Yeah, first of all, Elizabeth, it's always so great to have you join us, so thank you. The kids' results that you just shared are really wonderful, and I'm wondering if in your view or the view of is this solely due to HICS, or are there other things that we're doing that we might encourage other states to emulate?
Yeah, it's a great question. We've been partnering closely with schools, making sure we're sharing materials with them. They've backpacked letters home earlier in the year, and we're doing a lot of great community outreach. We always try to share what we're doing and what we see that might be working with other states. Obviously, this is a really new process, so the states have been doing a great job sharing best practices and learning from each other.
Great, thank you. We've continued.
Questions? Okay, keep going.
Sure. We've continued to see steady growth in our membership since April, including a consistent conversion rate of about 26% of individuals who qualify for Health Connector plans coming out of MassHealth enrolling with us. This chart here shows our new members from MassHealth in green, alongside MassHealth departures in blue. But an important note, not everyone departing MassHealth qualifies for Health Connector coverage. There are voluntary disenrollments, members who passed away, and members who don't qualify for MassHealth or Health Connector benefits who are included there as well. But we do expect our enrollment activity to ramp up through the fall as that departure activity ramps up and as we head into 2024. A key goal for us has been to keep Massachusetts as a national leader in insurance coverage and to minimize the number of uninsured residents at the end of the redetermination process. While we have really good sightlines into MassHealth members who transition to connector coverage, it's more challenging to assess changes in other market segments, such as employer coverage. We do know that about 12,000 of the individuals who now qualify for unsubsidized QHPs and who haven't enrolled have reported either having or having access to other coverage on their application. And in a recent survey of our eligible but not enrolled individuals, we saw about 60% of respondents indicate that they had insurance coverage. And whether that reflects other coverage being more likely to, people with other coverage being more likely to take the survey, or an underreporting on applications due to non-response by people who are covered elsewhere, is something that we're looking closely at, but I think is consistent with what we're seeing here, that people have made transitions elsewhere. More broadly, we're discussing with MassHealth, DOI, and CHIA how best to monitor changes in overall coverage rates throughout the Commonwealth as they emerge, since it will likely take some time for data to be available beyond what we can see in our system. We'll return to the board with findings from this broader analysis once they're available. I think we have a question, Eric?
Yeah, Eric, I see a question. Sorry,
Yes,
Eric.
thank you. I was just wondering on slide 14, how does that compare to other states today? Just looking at the lines and the difference, is that what other states are seeing as well?
I would need to go back and take a look at the data. Every state, has had a very different experience. Some states started earlier. They've seen a lot more departures to date. Some states are taking less time to complete this process. For instance, we heard last month from colleagues in Idaho where they've only done their unwinding process over 6 months and they're nearly complete. So it is a little bit different state to state, depending on which populations were chosen to start, et cetera. I would say from what we've seen on the exchange side that we are seeing a good number of people coverage.
Michael?
There's an echo.
There's a big echo. No.
That's not my comment. Okay, now it's better. I'm interested in the bullet point on slide 15 that says among survey respondents, 60% of eligible but unenrolled had insurance coverage elsewhere. I understand the eligible but unenrolled part could have insurance coverage elsewhere. I'm not completely sure I understand what interpretation of that sentence is. 40% of the people who are eligible for coverage but not enrolled in our coverage and responded to this, of the response to the survey, 40% of the ones who are eligible and unenrolled have no other coverage. Is that basically right? So we're missing 40, roughly speaking, that would suggest, ignoring the response issues, which you mentioned, 40% of the people that were eligible but haven't yet enrolled don't have other coverage. Is that basically, or maybe yet?
Right. So we did see that in the responses that some people took the survey and they said, I don't have coverage yet. I think we can get into on this slide next, a couple of the barriers that they've reported. And so when we asked, what could we do better to help you get into coverage? We saw answers about affordability, which we know always tops the list as a barrier. But we also saw some answers here about looking for clearer instructions on next steps or getting additional help with shopping, answering questions. And I think we're taking a fresh look at our messaging with this feedback in mind to see if there are improvements that we can make that would better support people who said that they were still struggling even after they heard from us. And many of them remembered hearing from us. You can see here, 2/3 of people said, yes, I got your letter, I got your email, I got your text. We saw a few people who also said, I heard from an assister or a community organization, or even my provider sent me something in my patient portal to let me know about enrollment and making sure I stay covered coming out of MassHealth. And so they're getting these messages and we're looking at how to take this feedback back. We're sending lots of messages, but could we tweak the messaging? Could we use some different formats? What can we do better to help those people who still have reported that they're not covered?
I'm sorry.
Go ahead, Michael. Sorry.
Are they subject to a penalty for not being covered?
It will depend. If they are above 150% of the federal poverty level and they go for more than 3 consecutive months without coverage, they could be facing a tax penalty, yes.
Marissa, have I got the math right that this is the total universe, the 100% of this is about 61,000 people?
I would need to double check the total population for our eligible but not enrolled survey. I think it was higher than that. We have people who may have applied who were not coming out of MassHealth who were also included in the survey.
Okay. I was just thinking of MassHealth transition. Okay.
Yes, they're a subset. I have some other questions on this. I can hand over to Jason on outreach.
Great, thanks. Thanks, Marissa. Good morning, everyone. On direct communications, we're ongoing. We continue to keep pace as the number of newly eligible people coming from MassHealth continues to increase. We continue to encourage enrollment, particularly around deadlines in terms of timing of messaging. And as Marissa said, we are in the process of reviewing feedback to try to determine best performing materials to ensure we are remaining as effective as possible. 2 other notes here. As you see, 950,000 communications through August. That's mostly on the subscriber level, not the member level. But if we haven't hit, that was through August. So if we haven't hit 1 million by now, we will pretty much any day, which is a notable milestone here. And then we did start outbound calls in July. The live agent conversations have been effective. The bulk of outbound calls last month targeted newly eligible people or people who had received their blue envelope and still had time to provide account updates to MassHealth. Next slide, maybe, Marissa. Thanks. We continue to participate in a variety of public events, including visibility and enrollment events, and we have an upcoming steady stream of regionalized press events. We've done more than 30 community activities around the state. This is where attendees can get information about the Health Connector and redeterminations. Some of these include lit drops and tabling in public areas in cities before enrollment events to try to drive traffic to those. The enrollment events do continue to build steam in terms of people coming specifically to enroll, but they've been really great in terms of being sort of outsized visibility events. We've been getting 500 people or more to pretty much all of these. Some of the big partnered events like last month, Southeast Asian Water Festival in Lowell brought 15,000 people or more. So we're out there, we're highly visible. We continue to chip away on the earned media side with press conferences. Those continue to be ongoing in conjunction with MassHealth and Healthcare for All. We include local media. We also post a live feed on our Facebook page for every one of these events for out-of-town reporters who may want to watch. And then yesterday's event in Lawrence with MassHealth and Healthcare for All kicked off, and every other week cadence pretty much through October for redetermination. As we do get into October, we're going to increase our open enrollment messaging at these events, obviously, and we'll attach additional activities in the communities we're visiting in October as we start to get into open enrollment and kind of overlap both sets of messages. The next slide, Marissa.
I always had a question, sorry.
Sorry.
Hi, thank you. I know I asked the question earlier, but I would encourage the staff to continue to look to other states to start to gather data. When I'm looking at this, the efforts are incredibly good, but it's hard to understand whether we're being effective, whether it's working. And the only way I can think of whether to assess whether it's working is to look at all the other states and see, well, how are they doing? And if we're doing the same or better or worse than others that are going through the same process. So just like you showed us earlier, how the kids in the CMS ruling, how we're doing really well compared to other states, that was really helpful to show whatever we're doing is working. I think it might be helpful for us as we're moving forward to really make an effort to look at other states and how they're doing. And then we can use that as a benchmark to say, all right, well, whatever we're doing, it's getting us to this result. And this result is on par with other states or below or above. Just a thought that keeps coming back into mind as we're looking at all these efforts.
Thanks, Eric. Audrey, we touched on this briefly in the prep call. Do you want to share what you shared with me, or is it not ready for prime time?
I'm happy to share. And Eric, I would just say we're completely with you on that approach, and we are looking very closely at what other states are doing. And there's lots of data sharing and just sort of anecdotes between states about different strategies they're taking. But just to kind of get down to brass tacks on the numbers. So right now, the Health Connector is enrolling about a quarter of people who lose Medicaid who become QHP eligible. And that looks higher than almost every other state marketplace, period. And we're kind of hovering around some of the other states that are taking steps that I would consider as aggressive or innovative as we're taking. Some of the other states that are kind of up there in those numbers, Marissa or others jump in, but are doing automatic enrollment of people, are paying for the first few months of people's premiums when they move over to Marketplace. We're not doing that. But some of the states that are very forward leaning on this are kind of up in those higher numbers around where we are as well. But just for context, because I think that kind of 25% conversion rate, if you know a lot about Medicaid to Marketplace transitions, we know that's actually very favorable, but just sort of the untrained ear, you just may worry about the other 75%. And I assure you, we are worrying about the other 75%. But for context, as a baseline, CMS analyzed nationally what percentage of people pre-pandemic moved from Medicaid coverage to Marketplace coverage. So we had kind of a baseline of like, what do those transitions typically look like? It was 2%. So we're at about 25%. So your point is a great one, and we're really looking into in terms of how much can we look at specific strategies we're doing to see how much fruit they're bearing for us so we can really double down on those. But I would say overall, all in, all this stuff you're hearing about looks like it is adding up to a far better than average movement of people losing Medicaid into Marketplace. So that's positive, but that doesn't mean there's not more we can do on the kind of the granular pieces and the specific techniques, because maybe there's places where we can say, you know what, that doesn't look like it's doing a ton, but oh wow, this is really bearing fruit. Let's put more resources into that.
Excellent. Thank you. Wonderful
Sure.
data.
Great. And I see Elaine's hand also.
Thank you. Good
Today.
morning. Hi, how are you?
Good morning.
My question is in the public outreach, and maybe it's a two-part question, but it's kind of along the same umbrella. To what extent do you see, or would you measure the level of language access being a barrier throughout all of the public outreach, throughout all the different ways that we're reaching out to the public? And in line with that is also with our growing immigrant population, what are we taking in just from all of that? You know, I mean, I guess I'm going to leave it at that, but it's really kind of the growing immigrant population and language access is what I'm curious about.
Yeah, good question. So in terms of language access and, you know, at least in terms of our materials, you know, we've been working with MassHealth and Healthcare for All to make sure the materials are available in a variety of languages. You know, certainly the higher frequency languages are well covered, and we make sure that, you know, those are tailored to a, you know, specific audience and a specific community. You know, not only in terms of language, but also platform and mobile media when there's an effective outlet there. And we do make sure, you know, when we go out into a community or at an enrollment event, we do make sure that we have navigators, assisters, or other folks on hand who can speak a variety of languages, especially those, you know, that are important in a particular area. So, you know, we try to cover our bases there as best we can. And, you know, our navigators speak on whole at 20 something, almost 30 languages. So chances are there's somebody who can show up and help us out on language access.
And I would just add on the immigrant piece, I mean, the navigators we work with are very close to the immigrant populations in the communities they serve. So that's sort of a strong foundation we have. I would also just highlight the work that Healthcare for All is doing with MassHealth and the Connector is leveraging small regional community-based organizations to do the canvassing and door knocking that they're doing around the state in places where we know there's more Medicaid enrollees. And they've taken great pains to make sure that it is members of that community who are knocking on doors in that community, not one for one, but, in terms of an immigrant from this country knocking on, an immigrant's door, but in populations where there is, a significant Brazilian community or Haitian community, those are the organizers that are going around and drumming up awareness and knocking on doors. So that's been kind of baked into a lot of those tools as well. We would really welcome a conversation about other ways we could be thinking about that, because it is a huge area of focus for the state.
Thanks, Audrey.
Excellent. Thank
Nancy.
you.
Yeah, thank you, Secretary. I just wanted to point out that one of the reasons we're doing better than other states, there are obviously many of them, and staff have talked about that. A major reason is because we have the Connector Care program, where we make available more affordable coverage that is better, and coverage that is much easier to compare than in other states. And I was just reminded of this in class this week when I had students shop for coverage on 10 other exchanges, and not one of them has nearly the rates that are as low as ours, the coverage that is as good, I would never say ever comparing health insurance is easy, but it is really hard to shop on other states given the choices. So I think we should remember that. I think we should take pride in it. I think we should really always resolve to protect it. And it, is to me the most important part of the conversation we're going to have about the seal of approval. We have created better policy approaches and better preconditions in our state than any other state has.
Thank you, Nancy. I'll remind you of that in our next conversation, but I think it's a really important point. Matt.
Sorry, I just want to second what Nancy just said. The sophistication and the diligence of this effort is really, really impressive. And it's one of the reasons I'm proud to be on this board. I think we really are, based on the work that we've done as a Commonwealth since this whole structure was set up, has really just positions us extremely well to navigate a challenge like this. And, the close collaboration between MassHealth and the Connector, that's really something to acknowledge here. And I don't have enough of a window into what other states do or how well they do that sort of thing. But I think it's critical to the success here that the Connector and MassHealth work together in such a productive fashion. And behind it all, I think, is something a little harder to sort of quantify, but is clearly an important part of the success here, is just the collective commitment to making sure that as part of this transition, we we mitigate the risk of backsliding on our ultimate goal, which is making sure people don't have a gap in coverage. So it's super impressive to me. And I just wanted to note that.
Thank you, Matt. Really well said. I appreciate it. I'd add also the partnership with Healthcare for All and the community outreach that Elaine flagged. I think that we can't do this from Beacon Hill. It really is a grassroots effort, and that has paid off. And we have to remember that, the legislature explicitly funded that, and I think it's really important that we learn from this, particularly as we continue to try to reach people, because we're heading into the time where more people will, by definition, potentially lose their coverage. So we really have to double down on what's worked and adjust what isn't working as well as we hope. So I think the partnership is terrific. I think I need to move us along on time, but Nelson, are you up? Who's up next? Do we have some additional presentations, or is it still Jason?
Yeah, just real quickly on paid media. The campaign continues. A lot of regional ethnic outlets, particularly a big burst promoting enrollment events to make sure people are aware that there's an opportunity to sign up locally. Overall, digital and out of home, which includes billboards and T stations, continue to fare very well, generating big impression numbers. And then new for this fall is a partnership with the Sports Hub. That's the sports radio station. That's just an absolute ratings behemoth. And New England Patriot Kyle Duggar. We spent the morning with him earlier this summer, getting all sorts of material that includes spots that are on the air during the week and on Patriots broadcasts. And we have some online video material that will focus on redeterminations and enrollment deadlines, and also some stuff around connected care expansion. So as we sort of overlap messaging going into the heavy part of the fall, Kyle Duggar will be talking about both redeterminations and connected care expansion.
Great, thank you.
From a contact center perspective, service levels remain high at 94.28% for the month of August, and we are seeing increase in volume month over month. So we were offered 79,691 calls in August compared to 64,079 in July. But overall performance remains strong. We had an abandonment rate of 1.17% as well.
Thank you.
Then we also have our second contact center vendor, Maximus, who's performing outbound calls for us, and to support some of what Jason described in the previous slides. They've continued to make outreach to members, including for campaigns related to ID proofing, supporting members who are unwinding from previously having MassHealth coverage, payment reminders, and messages to mixed households with the reminders about the blue envelopes that they're receiving and the actions they need to take. So far, they've made 159,000 calls, with 30,658 connecting with an individual, and 84,618 voicemails left. And in addition to doing the outbound calls, Maximus also supports with document processing. And on some of the peak days that the inbound call center experiences high volume, like Mondays or Tuesdays after a holiday or the deadline days, Maximus is supporting document processing. So Accenture, the primary inbound call center, can put more resources to provide a smoother experience for people calling in.
Great. So we've said before, and we'll say again, that supporting coverage transitions during the Medicaid redetermination process is our top priority, particularly as efforts intensify during open enrollment. And we look forward to returning with additional updates at our next meeting.
Great, thank you, Marissa. Any questions before we move on? Okay, well, the next agenda item is a presentation of the 2024 seal of approval, and this presentation will end in a vote, which will be a request for the board to vote the 2024 seal of approval to all qualified health plans and qualified dental plans. Marissa Woltman will present again with Samuel Adams, and Marissa's going to kick us off.
Great, thank you. Today, we'll request your vote on the final seal of approval for qualified health and dental plans for plan year 2024. This is the third and final installment in our 2024 seal of approval discussions. In March, we launched the process proposing plan designs largely consistent with our 2023 designs and built on several years of equity initiatives related to chronic disease management, with new items on foregone preventive care, maternal health, and behavioral health. In July, we reviewed carrier responses, and today we'll review connector care program design and rate changes. Of note, we'll focus on non-group rates today, but we'll return to a future meeting with more details on 2024 premium changes for small groups and the landscape there. Our approach to 2024 is colored by a number of considerations and initiatives underway. We'll see sizable growth in the merged market as individuals leave MassHealth, and we'll see shifts within our population as tens of thousands of members move into connector care under the new pilot. We have a new carrier landscape in connector care, and carriers also engaged in a new rate review process with the Division of Insurance this year, including a new public comment opportunity and publication of rate filing summaries online. And all of this is against a backdrop of affordability challenges we know all state residents are facing, no matter where they get their coverage, as we've seen in our own data, as well as analyses by the Health Policy Commission and SHIA. Against that backdrop, we proposed a product shelf seeking to prioritize high-value comprehensive coverage and received responses from 8 medical carriers and 2 dental carriers. The merged market average rate increase as approved by DOI for medical plans is 3.2% before aging, lower than last year's 6.6%, and other states that we've seen put their 2024 rates out. For example, Connecticut had increases over 9%, New York around 12%, and Maine around 15%. We did observe variability across carriers and plans, though with a range of increases and some decreases as well, which Sam will review in more detail.
Looking at the top level, the QHP product shelf contains 8 medical carriers submitting a total of 46 non-group and 56 small group qualified health plans. Each issuer is required to offer a standard plan design on platinum, gold, silver, and bronze metallic tiers. These standard plan designs seek to provide copay first cost sharing with focus on reducing costs for primary care visits and generic medications for plan enrollees. The plan designs, inclusive of benefits, deductibles, and copays, are very similar to those available in 2023, with adjustments to primarily account for changes to stay within the federally required actuarial value range for each metallic tier. As mentioned in our opening slides, the average rate increases before aging for unsubsidized and APTC only non-group membership is 3.8% increase before aging and 5.5% increase after aging, assuming a member stays in the same plan at renewal. While the average overall rate increases are among the lowest in the past 5 years, there's variability by metallic tier. In silver, the 8.4% increase is driven by a variety of factors. The expansion of connector care issuers has led to a dynamic shift in issuer membership projections and plan administration considerations on the silver tier, which is the underlying plan design for the connector care plans. We have also noted in the newly available public rate summary publications available from the Division of Insurance website that some carriers are projecting lower utilization than previous claim years experience, which is a driving factor for rate decreases or increases below the merged market average. In our next slide, we illustrate how in Worcester, the unsubsidized and APTC only non-group premium changes may vary by carrier. So reading this table from left to right, we've illustrated the membership share of each carrier using August 2023 enrollment. And the third and fourth columns reflect the enrollment weighted premium changes between 2023 and 2024, with and without aging and assuming mapping to the same plan at renewal. This final column shows an illustrative example of a 40-year-old individual in Worcester with a 2024 unsubsidized silver plan premium, meaning the premium reductions from APTC or other subsidy do not further reduce the premiums in this example.
Oh, sorry. Did anyone have any questions on the last slide before we move on? That's kind of the money shot. It's what people will experience after our vote. Matt, sorry, I didn't see your hand.
Can I ask a question? It's Michael.
Yes, Michael. Yes.
I don't know if someone else had their hand up. Anyway.
I don't see the other hands, but did I miss somebody? No.
Okay, then I'll just ask my question. The 8.4% silver number, you said a few things about what was going on, some competition and other things. I don't disagree with any of that, but if you look back at that number, it's pretty aggressive and pretty out of line with some of the other places. And it makes me worry about some other dynamics that might be going on, because it's the silver bid that sort of drives the federal subsidy. And so I won't claim to understand. I'm watching Rena, seeing what she's going to say here about how much flexibility there is in how premium increases are moved across metal tiers and other types of things, and how the actual rate setting process goes. It's the nitty gritty of that's not really a Michael thing, but it is odd to me that there's so much of the cost increase is being shouldered in the silver tier. And maybe that's fine, because it just creates more subsidy so maybe we're really good with that. I don't know. But if you have any thoughts on that, or someone else has any thoughts on that, I'd love to hear them.
So, Michael, it was kind of startling to me to see as well. I guess I would ask the connector team to explain, is that a function of changes in the benefit plan design because of the actuarial value calculator, more on the silver tier versus other tiers? Is that a function of the mix of carriers that exist on the silver tier versus the other tier? Because those would drive a different dynamic in the rates. From a pricing perspective, Michael, the carriers cannot put more in one benefit plan versus another. They're constrained. So it's got to be a function of something else that's happening.
And one of the big driver, probably the big driver for the higher increase, is because the new connected care carrier entrants need to add a CSR load. So that's the first year that we're seeing that. While the current connected care carrier, they already all have a CSR load included in their rates.
So this is going to be a recurring theme in my comments throughout this entire presentation. I think we need to think long and hard about what we're doing here to the market. By bringing in higher cost carriers into the silver tier, I know we think we're doing something that's helping choice and all of that, but if it's driving costs, I don't see how that makes sense.
Yes, I'm sorry, Eric's going to talk.
Eric, and then Michael.
Yes, I was just going to point out, and I echo a lot of what Rena says. It's a balance, right? You've got to look, we'll hear about this in a minute, where we got to maintain competition. We want to maintain access in geographies where people don't have access to more than one carrier. So it's a balance, of course. But one thing I do want to note is you look at Tufts Health Plan Direct and you look at WellSense. Those are smaller network plans. Those are plans that are focusing on where people are getting care and driving them to lower cost, more efficient providers. And that's a consistent theme. We're hearing it from the Health Policy Commission. We're going to hear it from CHIA. We're going to hear it everywhere. And that's also a theme I think that's happening in the expansion of the connector care carriers, that we're adding in very broad network, very rich plan designs. And it's apples and oranges when you're comparing it to Tufts Direct and WellSense. So I just think it's something we're going to have to continue to look at. I know the staff is looking at that longer term. Thank you.
So first of all, that was an exceptional comment, and this is going to be very consistent with what Eric just said. Can you go back to the 8.4 slide for a second? Yeah. So these, I think, are averages. And what's getting missed, if you look at this 8.4, which is the average increase, it might be that's just the wrong metric for how we think about that. If you go back to the slide that we were just on and you see the 2.3 and the -2, maybe the right way we look at the information should not be looking at the average. Maybe we need to be looking at information about what's happening to the lowest cost ones, or the ones that are getting a lot of enrollment. I actually don't have a problem, to Eric's point. If there's a more expensive plan with a broader network, but people choose that plan over the narrower network plans and are willing to pay the higher premium, that doesn't bother me. What I care more about is that people have the opportunity to choose a lower cost plan that has the coverage, the financial protection that we want. And if you look at this slide, it's a much less scary picture than the other one, because you can really focus where a lot of people are, and you can really realize that, in fact, if you want WellSense, you can actually get a lot better. So I think the alarm from the average slide gets taken away in this slide, but the message is kind of buried because of how we present the information.
Matt?
No. I think that's exactly right, Michael. And that was my reaction as well. Once you dig down to the specific rates of carriers within this metal tier, it provides the fuller picture. And I think the strategy, and I'm sort of echoing what Eric said, the strategy here, as I sort of understand it, is to provide a range of meaningful choices, right? By adding the new carriers to connector care here, that's what we do. We have different value propositions among the different plans here. We have broader network, in some cases, just a stronger brand name type coverage. And then you have more narrow network, more affordable options. And to me, that is precisely the point of an exchange, is to set up that kind of a shopping experience and decision making on the part of our enrollees.
Thank you, Matt. I have a question for Rena. Would you say that while we have presented to the people we serve what Matt described, which is a range of shopping alternatives, would you say like 3 years from now, the payments even to the higher end providers will drag the average up, or is it totally based on, like, is this sort of like the tyranny of the mean, that it looks okay now, but it won't be 3 years from now? Is that your concern? I'm trying to understand the relationship between premium choice and cost in your comments, or did I misunderstand your comments completely, which is also a possibility?
I don't know if you misunderstood my comments, and I'm sure I wasn't as clear as I could have been on this. I completely agree with everyone that representing the range as opposed to the average is the right way to do things. I guess I'm prepping for the part of the conversation where we're going to talk about subsidizing the higher cost carriers. And that causes me great concern. I don't think Secretary, the average is going to increase if we mask the cost of the higher cost carriers and allow more enrollment to go there, as opposed to letting people see the full breadth of cost options and make their choices accordingly. But I don't see these costs among the more efficient, narrower network plans and the broader network, more expensive plans. I don't see those converging to any sort of mean over time. I think they operate in completely different spaces, and the providers that they deal with are just more expensive.
Okay, I've got it. That's what I thought, but I wanted to understand the point you're making. So we're moving into the next phase. We'll move into the point you're trying to get to, which is sort of the dreaded smoothing conversation, but we should probably get there. So I'll ask the team to keep moving. Thank you.
So against this backdrop of rate changes, we're preparing for, in Audrey's words, an unprecedented connector care program with expanded eligibility and expanded choices for members. And we've had to consider how we provide subsidies in the context of these changes, particularly on the topic of reducing the differences in price between lowest cost and higher cost plans, which we call premium smoothing. Premium smoothing is a tool that helps the Health Connector ensure members have a number of affordable options while still incentivizing enrollment in low-cost plans. It's something we've done in various forms over the years as we sought to balance a number of competing goals. We look to provide affordable premiums for members such that they have several choices of plans. We're also trying to create stable premiums and avoid big shifts from year to year, making the program more predictable for members and for carriers. and we hope to incentivize low premiums overall. The proposed approach for 2024 is similar to prior years and focuses on lower income enrollees and lower cost plans, gradually phasing out as income and plan costs increase. And of note, we have proposed no smoothing for the pilot population. Enrollees in those income brackets would pay the full difference between plans as they do today. While we would plan to use the same general structure for smoothing as outlined in the RFR, we recommend implementing a cap on smoothing this year as the result of the wide variation in silver premiums that we've discussed. This would mean excluding plans more than $375 more expensive than the lowest cost plan in a given region from smoothing, unless there were fewer than 4 choices that would be reasonably affordable to enrollees. In developing this approach, we thought about a few considerations. First, expanding access, providing some smoothing for carriers newly joining Connector Care supports meaningfully expanded choices for members. In terms of targeted member support, we focused on the program's lowest income members and helping shape Connector Care as a bridge between MassHealth and unsubsidized coverage. Regarding cost containment, capping smoothing payments signals the Health Connector's expectation that carriers engage in competitive pricing for the program and in the market generally. And on program stability, requiring all carrier participation in part responded to regions where only 1 or 2 health plans were available in Connector Care, leaving the program vulnerable to bare counties. Smoothing helps establish new carriers in those regions. This year's approach leans more into the goals of member access and program stability rather than the cost containment goal. And we put our focus here this year, given our top organizational priority of making sure that people moving from MassHealth to the Connector see a pathway to maintaining coverage here. We know that there are alternate ways of constructing the program that can put more emphasis on controlling cost, and we're committed to exploring them to see how we can further advance affordability as well as access in future years. And on this slide, we've included an example of how this proposal would play out in the Boston region. Members in every region on this map would have access to at least 1 Connector Care plan at the monthly cost that aligns with what's considered affordable for that income range under the state's individual mandate and the affordability schedule that this board votes on each winter. And in the chart on the right, the premiums in red do not have any smoothing subsidy applied. So let me stop here for questions on this section.
Melissa, can you, do you have a comparison of so the ones that were smoothed, what the magnitude of the smoothing is?
I do, but I'm wondering, Edith, if you might be able to weigh in on that, because I think I'm controlling the screen poorly remotely and cannot access my other files.
Is it possible to loosely infer that, at least magnitude wise, by looking at the unsubsidized versions of the same carriers? So if you look at Fallon, you can see how big the smoothing was when you move to the plan types that are less smoothed.
Well, no, because I think that there's confounding variables about choice in there. That would be too rough an assessment. Maybe I'll take Nancy's question while the team looks to see if they can find the specific answer to Rena's question.
Actually, Secretary, I don't have a question. I have some comments I want to make, but I want to wait till people have all the information they want. So if it's okay with you, I'll wait.
Then I'll just filibuster. But
so maybe while we're waiting for the exact dollars, even just a percentage basis, like you can't tell from this chart who was smoothed and how much.
So
isn't the red indicating not smooth, and the blue and the black is indicating smooth?
Yeah,
so
but Eric, my point is Fallon smoothed when they're at 0, 49, 101, or is that actual? And where does the smoothing start and by how much?
I wonder though if I think there's 3 things that are happening. I think there's premium support smoothing and like size of choice and options, right? I don't think there's I think premium support and smoothing are different in my mind, but maybe I
Totally,
could correct.
totally
me.
agree. Totally agree.
So
the
the zeros, the ones in 2As, I think are different personally. But I'll be happily wrong on that if I am.
I think one of the questions that we have asked in the past is whether or not we're adversely affecting the market with premium smoothing, and if the carriers are looking at what's been allocated for premium smoothing and driving up their cost factor based on what they know we have available to smooth the premium for our constituents.
I see Edith on the screen. Are you ready to answer or praying for guidance?
Yeah. So, well, I mean, obviously it varies by plan type and carriers. You know, there's a higher level of subsidies for the lower income people. So the more smoothing that we see is for Harvard Pilgrim and plan type 1. So we're smoothing like 50%. So it means like $165 basically. And
Did you say
then
15%?
50.
50.
yeah, 50% for plan type 1 and plan type 2A.
Okay.
Yeah, so that's in the second tier. But then when you look at plan type 2B, it's a very small percentage of subsidies. So for Harvard Pilgrim, and I'm picking like the highest cost plan, it's $28. And if you want more specific on some other carriers, happy to tell you how much smoothing there is.
Why don't you just take us through that just so people are grounded in dollars?
In dollars?
Or dollars or percentage, whichever is easier. Do people mind? It would help me.
It would help me too.
Okay.
So in plan type 1, for example, yeah, so there is no smoothing for Wildlands, Tufts Direct, $22 for Fallon, $99 for MGB Select, and $165 for Harvard Pilgrim. And that's the same thing for plan type 2A because they have the same level of subsidies. For plan type 2B, so no smoothing for Wildlands and Tufts Direct, $1 for Fallon, $75 for MGB Select, and $120 for Harvard Pilgrim. For plan
Edith, I'm sorry to interrupt you. Now, you're talking about Suffolk County here. Are these numbers different and is there more smoothing? I'll make it up in Berkshire because there's fewer, because they're trying to entice providers there.
It varies a little bit. Yeah, by region, because carriers have different rates by region as well. And it also varies based on who's the second lowest cost plan in each region, because that is basically the leading one of the leading contributor in terms of APTC subsidies. So if you have, a carrier that is pretty high cost as the second lowest cost plan, then there's more federal subsidies.
And there's more smoothing by definition in that case.
Less smoothing if there's a lot of federal subsidies.
It may be worth adding too that when you look at an example like the one on the screen here, where you have some of our very lowest cost plans in Connector Care, WellSense and Tufts Direct, and folks have noted those are narrower networks and have through their own strategy and success developed these very low cost options that are dominating the Connector Care program, and we expect will continue to dominate the Connector Care program and are in fact dominating the non-Connector Care program in the marketplace because people are price sensitive and are looking for those options. But if you leave some of these areas where you have those really low cost options, the difference between the lowest cost options available there in Connector Care otherwise and some of these new carriers coming in are not as great. So to Edith's point, there's less smoothing needed there or even at issue, because right here, what you're looking at is like the widest possible range of pricing. So just wanted to note that that's not the case in every part of the state. And in some of those places where you don't have Tufts Direct and WellSense and others, those are some of the areas where we've gotten down to one carrier, and was part of why we wanted to bring in the additional statewide carriers, just to buttress the program and make sure we had, robust carrier participation, so that we were never vulnerable to a carrier saying, I'm the only carrier in your county, and you know what, I don't want to be there anymore, and then we'd have nothing.
Sorry, Eric.
Yeah, I would just echo Audrey. I agree with that approach where there's geographies where there isn't competition, and we have to ensure the stability of the program and access to care. Those areas are where smoothing might make some sense. In areas like this, where there's an adequate number of carriers, it seems less compelling to need to smooth, at least long term. This year you might need to catch people coming off the other plan at MassHealth, and I understand that. But I think what you might be hearing from several members of the board is having choices is great, but having it subsidized may not be needed long term, may not be the best track for cost control. Having people buy up to the more expensive plans might be another avenue to look at, unless they don't have options.
Thank you, Eric. Michael.
So in the spirit of what Eric said, I do think this is going to be an ongoing process to get this right. And I think this year, because of the transition out of MassHealth and a bunch of things, we might do things somewhat differently than we might do going forward. I think we need to think through that. I think part of the issue is there's different motivations for smoothing in some ways. The one that I find most compelling is that sometimes, just for variation and actuarial assumptions and stuff, a plan may be a little bit off, and you could end up with a lot of instability in the lowest price carrier or the zero price carriers, and that can induce a lot of switching that you don't necessarily want to have for really not underlying cost reasons, just some sort of variation in the assumptions that folks have made or other idiosyncratic things. And so you want to think about stability over time in the premium of each plan relative to necessarily stability, the gaps between them. When you get up to the higher levels of subsidies, the MGBs or the Harvard Pilgrims, I think it becomes, over the long run, a harder case to make for subsidizing those folks that have chosen the broader networks. And I can understand, and again, I'll be fine in a moment, because at some point, Secretary Walsh is going to ask for a vote, and I'll be fine. But I do think we really need to think through what the rationale is behind the subsidies of the higher cost carriers. Because I don't have a problem with them, as opposed to making sure that you don't have a ton of switching between the carriers that are really struggling to keep costs down and doing things that are enabling them to do that. The WellSenses or the Tufts in this example.
No, thank you, Michael. And just in the interest of concern of my driving for the vote, this is exactly the conversation we should be having as a board. I think that my only concern is we probably won't solve it today, and it is likely a multi-year effort that we need to undertake and kind of resolve to, resolve the very important points of view that we're all reflecting here. So I don't mean to cut off discussion at all. I want to make sure that everybody understands the dimensions of the problem, and I think we're going to need to be bringing some additional information back. So Rena, and then Nancy, and then I'll look to Audrey for how we want to what we want to do at this juncture. But
Thank you. Appreciate that. I agree with what Michael just said about the stability in the carriers that have shown success in connector care and trying to keep their population stable, and allow members to stay in one place. I strongly disagree with subsidizing the higher cost carriers for a variety of reasons. Number one, I think it is a a dangerous precedent to set. And having been on the board for a long enough period of time, I've watched us make decisions that we felt were the right thing to do in the short term, but we knew were not the right things to do in the long term. And unraveling those decisions is incredibly painful. So, this is not something that you just turn it on one year and turn it off the next year. And even if we say we're going to do that, we're not going to. And that I find very concerning. These carriers are higher cost, whether they choose to be higher cost or it's, it is what it is. I think in markets where there's such a dramatic difference between carriers, we have to question if they even want to be in the connector care business. And by subsidizing them, we're basically forcing them into a business that they may not want to be in. And all we're doing is masking the cost and frankly taking on the cost as a state that I just think goes against everything we're trying to do about affordability and awareness and transparency. So I think I've beaten this into the ground for myself as much as I possibly can, but that is how I feel about it.
Thank you, Rena, and thank you for continuing to help us understand your point of view. I do wonder a little bit about geo-adequacy in this context, particularly as it relates to Cape Cod and availability of providers there. But I don't know enough about the western part of the state, but I know one high-cost provider is the only, the geo-adequacy in whatever region the Cape is for us is something we should talk a little bit about. But Nancy, you're up, and then Eric, or unless Nancy, you still want to hold your comments.
No. So first of all, I want to thank the staff for all the work on this. I think doing this every year is a lot of effort, and I think this year it was even more, particularly with everything else that's going on. So nothing I'm about to say is in any way critical of the staff. I think they've done a thorough and thoughtful and balanced job of putting this together. I'm strongly supportive of our policy direction of requiring all the carriers to participate. But participation of carriers is hollow if people cannot afford the rates. And I think I seem to be perhaps one of the only people on this call. I'm stunned at the rates that Blue Cross and Harvard Pilgrim and United submitted. As we have seen and talked about a little bit, they're anywhere between 50 to 100% higher than the other plans. I'm surprised that they meet the Division of Insurance standards for approval. They must reflect a level of actuarial conservatism that is difficult to justify, particularly given that we have risk adjustment and notwithstanding the comments that others have made about silver loading. And to Rena's comment, but I'll state it in a much edgier way than she did. The rates of these new carriers, to me, reflect a troubling disregard for the people that we serve. And I find that as somebody who's participated in health reform for a long time, especially ironic, given how often and how loudly many of them have talked for years about shared responsibility as a key underpinning of a health reform law that, frankly, for most of them has benefited them tremendously over the last 15 years or so. To me, the rates look like they believe in shared responsibility for high-income people, but no responsibility for people who have low incomes. And I would add that none of them participate in Massachusetts in the Medicaid plan either. And when you look at the rates, even with the premium smoothing, and I can really appreciate the comments of some of my fellow board members about premium smoothing. It is, hard to justify premium smoothing, particularly when it isn't going to make any of those plans realistically affordable for the people. Although I'm planning to support the staff recommendation, but just by way of example, so most of our members are in plan type 2B, which means they have incomes between, less than $29,000 a year. Yeah, the cost for them in our biggest area, which is where I'm sitting in Boston, it would take them 25% of their income to buy Blue Cross. And, so obviously, even with the premium smoothing, that isn't going to be affordable. And, I support the rationale to try to give our members broader provider access and more choice. But this process, I think, makes really clear to me, some of the system failures that we have to address, and other people have talked about them. And the three that I, really hope we can continue to have not only discussions about, but work with others to try to address. First of all, we have tolerated a 2-tier health insurance system. We have one system for, most people who have high incomes, and we have another system for people who do not. And that's not just plans, but it's increasingly providers. This, to me, at a time when we are focusing on health equity in the Commonwealth, as we should be on our health equity agenda. I think it also shows a lack of sufficiently rigorous oversight of health plan rates. And I think that likely reflects us as a Commonwealth having not given the Division of Insurance the tools that it needs to do what has to be done. And in the health policy cost trends report that Audrey talked about earlier in the meeting, that's one of their policy recommendations. So I hope that we as a board and will do what we can. And, and it obviously, as others have said, reflects just our really abject failure over a very long time to be able to control costs. So, to me, at the root of all three of those things are that we've had this failed romance with the market, and using market forces to determine costs and quality and access. And, I think the HPC report actually does a very good job of showing how flawed an approach that should be in starting. So I think as we vote on this, we shouldn't have any illusions that the new plan offerings are going to increase plan choice and access and equity in any meaningful way. But I really hope as a board and as a Commonwealth, that we will really get serious about reducing premiums without sacrificing access. Because to me, this more and more and more is one of the, so many really troubling health equity issues that we have in our state.
Thank you, Nancy. Eric, Rebecca, then Feline, your hand went up and down. So I don't know whether Nancy, you're going to cede your time to Nancy, but
I'll go.
Eric.
I'll go very fast, and I want to let the others, like Rebecca, speak. I would just say that the carriers that are more expensive, I know, being in the business, Blue Cross Blue Shield, United, for example, and even MGB, they do offer solutions trying to get closer to the Tufts Direct, WellSense type of model. I'd encourage us all to continue to work with them over time. I know this is year one and putting some of these carriers into the program, but I think if we engage with them earlier, and if we have those discussions about cost controls and networks, different networks, incenting employees to shop for care, they have innovative designs. We're just going to have to work with them to make it work within the context of connector care. Right, thanks.
Thanks. Rebecca.
Yes, I just wanted to say that the Division of Insurance is certainly very concerned about affordability, and we have a more transparent and open rate review process that we have accomplished via regulation. The legislation hasn't gotten done yet, but what we have done was supported by both Healthcare for All and RAM, which are two entities that are often opposed. So we're trying to make the process as transparent as possible, and we deeply encourage all who are interested to look at our website and see what we've done, and perhaps weigh in when we accept public comment for the next rating period. And the rates across the market had been going up by 7, 8, 9%, and we've cut that down to 3.2% for the following year across the merged market. And certainly we would like it to be less than that. And I understand that these new carriers coming to the market and the broader networks and the idea of conservative pricing is probably on your minds, but I think, you know, over time we'll become more able to use the data that is seen from this year and following years to have a better understanding of stabilizing the market and providing as much health equity as possible.
Thank you, Rebecca. Matt, okay, Matt, and then
I'll be brief.
I had some comments I wanted to make myself.
Feel free as chair to take the floor, and I'm happy to follow in behind as necessary. Go right ahead.
No, okay. Nancy, I just wanted to, first of all, thank you everybody for their comments, but specifically your, well thought out remarks. I just wanted to make one comment that I think we should think about, which is the notion that in our attempt to improve equity, the equity is achieved by ensuring access to higher cost providers. And I am not actually sure that's true. And I'm obviously reflecting some bias and pride, I think, of the work that we did at Boston Medical Center as a system in really trying to meet people where they are in terms of care. And I would argue people had a higher quality, more equitable experience, maybe for some conditions at our organization than they might have had at other places in town. Maternity care would be a good example of that, even though there was a long way to go in improving our own performance, my former colleagues' performance in that space. So I just want to make sure that we don't, in pursuit of equity, find ourselves in a situation. I think choice and equity are different, and I just wanted to make that point. Matt.
Yeah, thank you. I'm struck by Nancy's comment about a failed romance with the market, and it's an interesting turn of phrase, and I think what the HPC helps us to understand, which you alluded to, Nancy, is where the market itself continues to fail, and thankfully points us in the direction based on what HPC has been set up to do. It's thorough analysis of data. It's piecing it together to understand how the market can be adjusted to work more efficiently and ultimately to provide greater affordability to those that pay premiums. And I'm struck by how limited the ability of the tools of the connector, even the division of insurance, should we ultimately decide to give them more authority or not. And us at the GIC, frankly, as large of a purchaser as we are, to really alter those fundamental market failures, I would say. So, I think that I share wholeheartedly the underlying concerns here about affordability, and I'm optimistic that because that's not limited to this group, but I'd say growing as an imperative and interest in many other areas, that the legislature will be more willing to take on some of these things. So I strongly support the proposal. I think, there's the balance that we've talked about many times that we need to strike here, is one that we strike in many similar ways as presented. But it does leave me with the very clear sense that that making real, sustainable, meaningful progress on affordability is a much bigger discussion than this board. And we all need to participate in that in a way that can generate the kind of will that's necessary to address those problems.
And I'm just going to add a quick comment if I can, Secretary.
Sure.
A lot of this is, we talk a lot about the insurance market. This is all about the insurance market. A ton has to do with what's going on in the provider market. And that's a bit of outside of our purview, but that's why the narrow network stuff's important, a whole bunch of things. Underlying, it's the cost of care, the provider market, and how that's functioning that matters. And I'll just leave it at that.
I mean, I'll just add a comment.
Sorry,
and then
Feline, I didn't see you.
we'll go to Feline. You know, one of the things I see in this perch, which is, you know, it's great that I'm sharing this, is a provider market that is really struggling. I think you'll be hearing over weeks and months to come more about that. So there's our very real concern about the cost of their premium increases, which the provider community would say are not enough. And, you know, and we're seeing sort of unprecedented challenges across the state. You know, service closures, facility closures, you know, people in my office saying I can't meet payroll next week. And so there's a lot to consider and balance here. And I think I'm going to have Feline and then maybe Audrey to wrap us up. So Feline.
Thank you everyone for this debate, and especially, you know, Kate, I appreciate what you kind of just ended with in terms of just understanding the real struggles. You know, when I think about this, I think about it in the context of you know, our members at 1199, in particular our personal care attendants, mostly women, and mostly women of color who, you know, it is absolutely critical for them to, when thinking about, I guess I'd say like this, it's one thing to have variation in range, of provider access. I think it's extremely important, but it's another thing to have those costs associated with them be in line with the affordability that our members have come to rely on, because if not, then there is no choice for them. Or very little choice. And so, you know, with that, I mean, I too welcome and look forward to kind of our continued discussion on the cost, the access, and ways that we strategize and partner for everyone in our Commonwealth. But you know, again, thanks for the discussion.
Thank you. Audrey, do you want to talk a little bit? We chatted a bit about how we as a board could get more information and conversation and maybe deepen our partnership with DOI. Do you want to make a few comments before we move on and call for the vote?
Sure, I'd be glad to. And I just want to express gratitude for the robustness of this debate. It's healthy, it's appropriate. This is among the most complicated issues that we grapple with in terms of balancing our responsibilities to members, some of whom are below the poverty level, don't have cars to get to providers, face language barriers, all sorts of challenges that we're trying to build around, and yet also balance our interest in sending signals to the market and to the healthcare system more broadly about how urgent affordability and cost containment are. So it's just great to hear the engagement and the feedback. And I would say we agree with nearly every single thing that has been said here. And our interest, particularly in this question around how we're sort of treating or responding to these new higher cost, broader network entrants into the Connector Care program. As I mentioned at the top, we've been chiefly focused on just sort of operationally getting these carriers kind of in the door in the first place for year one, and our interest in just really spending the next year working with those carriers, with you all, on developing a strategy that really allows for what they bring to the table to be in closer reach to people. So we look forward to those conversations. And you know, the carriers that newly joined the program worked really hard and fast to get into the program. We appreciate that, and we know they'll bring that same posture to the conversations we need to have about affordability. And we'd like to work closely with the board in the coming months to think about how we start to frame those conversations with the carriers and more generally. So look forward to that. I would also echo, I think Matt had made the point, this is not just a, a rate review approval question that lives with DOI, but this is a broader issue, certainly in terms of the underlying cost challenges we're seeing as a state and all grappling with. I do think it might be helpful for this board, just based on some of this discussion, to have a better understanding, particularly of the new DOI rate review process. So Rebecca, if you're open to it, I think it could be really helpful for us to have, whether it's Commissioner Anderson or Kevin or whomever makes sense, maybe come to this board to just share a bit more about that process, what its tools and what its limitations are and how it intersects with this work and these issues that we're continuing to grapple with, and where the connector fits and where it's sort of a broader market and stakeholder conversation. But again, want to thank everybody so much for the feedback that has been sort of shared along the way and today. And hopefully we've struck the right balance here. But we know this is going to be an iterative process as we go. And these are really, really thorny challenges, again, around balancing member protection, access with cost containment and the market signals we want to be putting out there.
Thank you, Audrey. Rebecca?
I just wanted to say quickly that the division would be more than happy to make a presentation and explain how the rate review process takes place in greater detail, and invite anyone who would like to provide public comment. Thank you.
Yeah, I don't know what the specific legalities are, but I was reflecting on the partnership between the connector and MassHealth. I wonder if there's a way to sort of deepen the relationship between, or at least the dialogue between DOI and the connector in a more formal way, and maybe they could be a standing agenda item for us once a year or twice a year as appropriate at the board level. But you guys are the lawyers that can figure that out for us. But I think it might be really helpful because we are a market facing organization, and DOI represents a much broader part of the market. So that could be really helpful. Audrey, I think I should move us on to the vote. But I don't want to cut. This is really, really important feedback, and it certainly has made me think. And and I have to say, it's great to hear actuaries explain things in ways I can understand. So I want to thank Rena for that. But anyway, so you want to do the dental plans and then we'll move on to the vote?
Yeah, I can make a very brief comment on our QDP shelf. So the dental shelf is stable. We have the same plans and same product offerings as available in several years at this rate. And the majority of the members are in the family low, which you can see will have an average rate decrease of 4.2%. I'm happy to also answer any other questions through email if as needed, just in the interest of time. And I think we've covered.
Sam, I did have a question, and it might be a totally unfair one. I should have asked one in the prep. People transitioning from MassHealth, where they had dental coverage, will likely lose it. Is there a way? I think a little bit about there was a Times article about the increase in childhood poverty in America, and one of the places they cited was access to dental care, and the sort of the role dental health plays in overall health, and our insurance plans haven't caught up with it. Do we have any sense of whether people are transitioning? I'm guessing when people transition out of MassHealth, they lose their dental coverage and don't get connected with dental products. Is that fair to say? And do we have any way to track that?
Yeah, I think that's right in most circumstances. I don't know if there is for pediatric populations, if there is supplemental coverage, but we do have a plan in that event. Audrey, you may have some insight.
Yeah, I would just share at the highest level, that is correct. Connector Care does not include dental benefits. So people need to purchase their own dental plan separately if they want to have dental coverage. People in Connector Care do have access to sort of very limited emergency dental services through the health safety net. But in terms of kind of standard dental coverage, that it's sort of a separate purchase that people make, and many people do when they come into the Connector Care program and other connector coverage.
Good to know. I didn't know that. Eric?
Do we know yet if the new 83% target loss ratio rule is going to have any sort of impact on these plans? Has that come up? Rebecca, you might have feedback on regulations.
Yes. the regulations are still under review. It's unclear when they will be effective, and it's unclear whether there may be transitional period until such time as the 83% ratio goes into effect.
Great. Rebecca, your hand was up. Was that just to answer the question, or did you have another comment? No. Okay, good. All right. I keep trying to move us on, but I keep asking questions. All right.
No, that's understood. I think we've covered most of our, next steps, so we can move toward the vote.
So there's language I need to read about the vote, which I guess I should get up. Is it on the slide, or I'll have it? Okay. So I'm going to call for a vote on slide 46. Is that up? Okay, great. No, I don't see it, guys. Can you move to the, oh, there it is. Okay. The Health Connector recommends awarding the 2024 final seal of approval to all QHP and QDP recommended herein proposed by the listed carriers. So I'd like a motion and a second, please.
So moved.
Second.
Okay. And now, Kathy, we need you to do a roll call vote for this.
Of course. All right. Rebecca,
Yes.
Michael,
Yes.
Eric,
Yes.
Martha,
Yes.
Dimitri,
Yes.
Secretary Walsh,
Yes.
Matt,
Yes.
Rena,
I support the seal of approval and geo access in certain regions, but I do not support the smoothing recommendation. So I don't know if that means I should be voting no. I think that is what I have to do.
Okay.
Nancy,
Yes.
Elaine.
Yes.
Thank you, everyone.
All right. So the motion carries. Thank you. The final item on the agenda is a presentation on open enrollment readiness preview, which will be presented by Marissa. You're going to need a throat lozenge after this. Jason, Nelson, and Michael. Thank you. Marissa's kicking us off. And I'd ask the team to be mindful of time. I'm sure people have a hard stop at 11. I know I do. Thanks.
Absolutely. So we'll just give you
I'll do a better job with time management next time.
No worries. We will give a quick overview of our open enrollment readiness, where we expect to see a lot of residents enrolling and changing health plans, and we'll touch briefly on our special considerations on Medicaid redeterminations and the expansion pilot. So just for a kind of level setting where we're at, the process for open enrollment has already begun with members that began last month when we gathered some updated data. We've sent them projections of their eligibility for 2024. Members who have a MassHealth family member have received their blue envelopes if they need to get those, and they'll be returning those over the course of the next month or so. And then over the course of the fall, we'll provide members with their renewal plan and premium information. We'll make sure that enrollment transactions get to carriers, and then we'll encourage members to make their premium payments for January coverage by December 23rd. And now I can hand over to Michael, if our slides advance. There we go, to talk about systems.
Thank you, Marissa. Good morning, everyone. So this slide here is really meant to represent that the process to execute open enrollment and allow new and existing members opportunities to shop relies really heavily on our release deployments, and it's made up of a tightly coordinated series of large-scale batch processing events. The entire process takes 16 months from the start of planning through the end of open enrollment each year. And it engages a lot of active participation from Health Connector staff, MassHealth staff, our vendors, and our carrier partners. We began planning for this upcoming open enrollment in the fall of last year to determine scope of both the HICS, which is our integrated eligibility system with MassHealth, and Softheon, which is our our enrollment premium billing and noticing solution. And this year, some highlights for our scope were the readiness for connector care expansion, as well as some health equity initiatives, including expanding race, ethnicity, and gender identity on the application. the core process here is really executed through our release management process. We focus a lot on system development and testing. In addition to regular release functional testing for open enrollment, we execute a lot of prod-like testing, which verifies at large scale that our large business events are executing as expected and that the system is handling all of that volume. So we have the yellow line represents where we are today. We had our go live in July, right before preliminary eligibility to kick off for this year. Prelim wrapped up at the beginning of this week, and we are on track for a go live at the end of September to support things for the plan load, APTC, and final eligibility. So we continue to stay on track and continue testing internally as well as with our carrier partners to be ready for 11/1. Anyone have any questions?
Great, thank you. Any questions? Wow. So thanks to the team for making up some time for us. I think that's the end. Oh no, there's more. Call center.
Real quick
Nelson.
on the
I don't want to cut
call
off the call centers. They're our face to the world.
the highlights on the call center readiness. We continue to support prepare for open enrollment and staff up with additional agents. We also have an additional buffer of agents that we've worked out with Accenture to have additional capacity if needed, if we get any unexpected call volume. And the other highlight here on the table below is our extended hours of operation for open enrollment. So as we do every year, we tend to have additional weekday and weekend hours around the peak deadline days in December and January.
Hi, real quickly on communications, in terms of direct communications, obviously connected care expansion is the key message. We want people who are moving into connected care. We're assuming their connected care is not particularly well known to non-members of the program. So we want them to understand how important switching into connected care coverage is for them and the benefits they're going to be picking up. So for current members moving in and for current connected care members on plan choice options, we want to make sure they know what's in store for them for November. And then for people who have applied in the past and didn't enroll or did an unsub only application, we want to make sure they come back and take a second look and see if maybe they qualify for connected care coverage now. So those communications are starting this month. Off we go. They'll be hearing from us regularly throughout open enrollment. Public outreach, obviously this is our busiest time of the year. This year generally has been very busy due to redeterminations, but we're going to do our usual heavy lifting around open enrollment on a community level, above and beyond the redetermination stuff. This will include not just our typical communities with higher rates of uninsured, where we want to continue to maximize our presence, but we also want to make sure we're in playing communities we identify as having concentrations of income in the 300 to 500 federal poverty level range. We're looking at some of the demographic data we have of current members in that category to identify communities that fit that profile. And this can be, not only new cities and towns, but also additional neighborhoods in cities where we already have a sizable open enrollment presence. And just a quick note on the enrollment side, we are hearing some crazy enthusiasm from our navigators around the pilot expansion. They're really eager to deliver new benefits to their clients. Training is ongoing there, but they're really knowledgeable on the system and won't need too much specific in terms of the expansion work. And then briefly on paid media, the marketing campaign will also feature connected care expansion. We are doing some focus groups starting next week that will include participants in the 300 to 500 FPL. We want to have that conversation to understand not only what messages resonate with them, but also in what ways they want to consume those messages. We want to learn if someone who has a significantly higher income level than our current connected care members view the program differently and tailor those messages to cater to those views and get people in the door. This may require multiple sets of messages during this open enrollment. But depending on the platform and the location of the messaging, we're going to make sure that we deliver the right messages to the right people where they want it. And we'll continue to do our outreach to communities in the traditionally higher rates of uninsured, particularly through the trusted, well-received media sources that we've been working with in the past.
Just briefly, in terms of our high level expectations, we're expecting a very busy open enrollment after several years with lower than usual membership gains. We've seen steady declines in Health Connector membership over the last 3 years, but you can see that our membership has already grown significantly since January, and we expect to see that trend continue into 2024. We'll also see a shift in the composition of this bar as more members move from the APTC only category to Connector Care. And in terms of the Connector Care pilot, while eligibility determinations for 2024 are ongoing and still far from settled, so our data that we have now shows over 96,000 individuals projected to qualify for coverage under the pilot, most of them in the 300 to 400% FPL range. And about 40% of them, or about 38,000 people, are current enrollees. Most of them will be new to Connector Care. You can see that today in this chart on the right, the majority are in APTC only coverage, but we do have some individuals at lower incomes today who will stay in the Connector Care program as their income increases for next year, helping them stay covered. And then we'll be busy in the coming months, making sure people have the information they need to choose, enroll in, and use their new coverage for 2024. And we will continue to focus on making it easy for them to do that and to keep you apprised of our progress.
Am I supposed to take our process going forward, or?
Nope. We will keep you posted as things develop. We look forward to returning with additional information over the course of the fall. I'm happy to take any questions before we close out.
Thanks, Marissa. And maybe before we close, I'll ask Audrey to, before I ask for a motion to adjourn, if there are no questions, maybe ask Audrey to summarize kind of next steps relative to the very rich conversation we had today as a board.
Sure. So I think just on the seal of approval piece, we'll plan to bring the Division of Insurance back to this board for a conversation about the rate review process. And maybe there's also an opportunity to think about Health Policy Commission, just sort of how we're pulling together the affordability conversation and better surfacing what are the connectors kind of angles into that, knowing it's sort of a broader conversation. So that's one piece. And then working with the board in the coming months is, believe it or not, obviously all of this discussion is getting ready for plan year 2024, but we very quickly pivot to early foundational steps to the development of our policy approach to plan year 2025. So we'll look forward to engaging with board members in one-on-one conversations so we can make touch points along the way with the board, more so than we've done in the past, to engage feedback and perspectives as we're shaping that, both with respect to smoothing and how we're navigating the all carrier participation, but general topics more broadly. So that piece will be coming soon. And then, as we've obviously been highly focused on open enrollment and the continuing focus on redetermination. So we'll certainly keep the board posted on our progress there, especially as our forecast and enrollment growth comes into even stronger focus, and we're able to do some of the kind of evaluating strategies as we go, learning from ourselves, learning from other states, learning from CMS. So all of that is to come in future conversations.
Thank you, Audrey. Nancy.
I've been pondering Secretary Walsh's equity comment, and I wonder if it'd be possible to share with the board some of the work that's been done showing the disproportionate amount of healthcare resources that flow to high-income communities because of the providers that people who live in those communities have access to. And how that leaves a much and disproportionately low amount of resources available to lower income communities whose residents have, as we know from all the work that's been done for decades, much higher health needs. And I think that begins to show the equity piece of this. In a way that I think is really important for all of us to understand as we continue to, and we have reports on that going back to the very good work that the AG office might have done even a decade ago. So I would never presume to talk about this to Secretary Walsh, given how she has spent her
And I
career.
probably shouldn't have reacted, but
No. No, and I think there's a lot of evidence that there's no correlation between provider price and quality and other things. But I think just reminding ourselves of some of the things here that create the imperative and I think the urgency for, continuing and really amplifying this conversation and in the service of trying to improve equity would be really important.
We did work at BMC, and even for a commercially insured patient, if that person was a person of color, they were more apt to be be served by a health system or a hospital or even a provider group that's paid less than less than market rates. So it was like if the market's 1, it was 0.8, 0.9, as opposed to 1.4 in other cases.
And I think it shows how there's just this inverse relationship between the need and where the resources are flowing. And I think
choice is really important. It's really important in certain clinical indications. But anyway, I obviously just reacted. So
no. Oh no. I mean, I've been sitting here pondering, just wanted to make that point at the end.
So. Yeah, and the question is, what leverage do we have to ensure that people can have agency and make their own choices? Because that's the most important part of people being healthy. So
and what new levers might we need the resolve to create? And I think that's another part of it. What do we have? What can we use? And what don't we have that we really need?
And with the expansion to 500%, we're going to see a different market. We have a hard stop. Shoot. Okay. I do need to. Matt, do you have a quick comment? And then
I just want to second everything that Nancy just said. I think that would be extremely helpful.
Okay, great. So Audrey, I think with thanks to your incredible team, we've given you even more homework to do in between, but at a very busy time of year, we can space this out. I mean, we're not going to solve health equity in one meeting. We have opportunities to continue to learn more together as a board. So with that, I will call for a motion to adjourn, please.
So moved.
Second.
Thank you. Kathy, it's time to take a vote.
Okay. Rebecca?
Yes.
Michael?
Yes.
Eric?
Yes.
Martha?
Yes.
Dimitri?
Yes.
Secretary?
Yes.
Matt?
Yes.
Rena?
Yes.
Nancy?
Yes.
Pauline?
Yes.
Thank you.
Well, the motion carries. I really, really appreciate everybody's candor and evident commitment in this conversation. Thanks again to the staff for really good prep. There's an incredible amount of material that came out that was, I thought, really helpful. And we'll see you all in a few months, in a month or two. Thanks.
Bye.
Thanks, everyone.
Bye.